This 15-minute video will review how to use the Queen's EPA Quality Rubric, or EQUAL. We'll start by providing a brief description of the purpose for EPAs and what quality means in describing EPAs. We'll then cover the elements of EPAs, which have been divided into these three categories: EPAs as discrete units of work, as essential and entrustable work of the profession, and as a curricular element. Finally, as we go through each of these, we'll review the items in the rubric to describe how to score them. In developing a rubric to ostensibly evaluate the quality of entrustable professional activities, or EPAs, there must first be an accepted goal for creating them in the first place. Building on this, a quality metric for EPAs should reliably measure the extent to which a proposed EPA meets this purpose. This rubric has been developed using peer-reviewed literature to define the purpose of EPAs, as well as the structure and content elements that serve this purpose. What is the goal of introducing EPAs? The goal in creating EPAs is to operationalize competencies to enable assessment that predicts future performance at an acceptable standard for the profession. In line with this goal, the defining elements of EPAs have previously been developed and described, as have a list of identified threats. Together, these elements provide the testable constructs for any rubric designed to evaluate EPA quality. In developing the rubric, it was noted that the elements of EPAs described in the literature could be grouped into three major categories: descriptions of units of work, elements related to professional entrustment, and curricular elements. Although other groupings are certainly possible, this framework was convenient from a use and a data analysis standpoint. Each of these three categories had 4 to 6 components that fit within it. In structuring the rubric, a Likert scale was used for each item to allow flexibility in answering and to enable a more robust statistical approach. Let's start by looking at the rubric considering EPAs as discrete units of work. Competencies, such as communication skills and professionalism, are woven into the various activities in the practice of medicine. These competencies evolve and mature over a lifetime. This makes them challenging, if not impossible, to observe directly and to assess reliably. By refocusing our approach for assessment on clinical tasks instead of the learners themselves, assessment becomes measures of actual observed behaviors in the clinical environment instead of inferred qualities of the learner, which are subject to interpretation and bias. At a minimum, discrete implies EPAs must have a defined beginning and end. Tasks that lack a defined beginning or end pose a major challenge to defining outcomes attributable to the activity. Although necessary, clear starting and endpoints are not enough to describe EPAs as discrete units of work. Beyond being discrete in timing, they must also be discrete in process. This is often described as being independently executable. That is, the task as described can be performed by the clinician to achieve the targeted and tangible clinical outcome, independent of contributions from other forms of work. In this context, a discrete task is professional work with a clearly defined beginning and end that can be observed in process and the output assessed, and the work done serves a specific and meaningful clinical purpose for a patient. It should also be recognized that professional practice requires a clinician to perform numerous activities. Some of these may be similar, some quite distinct. In considering EPAs as discrete units of work, it is important to consider each one within the larger EPA framework for the profession. In building a framework with discrete EPAs, it is important that each EPA can be clearly distinguished from the other EPAs. We'll now review the 6 items in the rubric that fall in this category. Here's the first item in the rubric. As you can see, it allows responses across a 5-point Likert scale. Each item has a descriptive anchor to guide rating. This first item looks to evaluate the EPA for a clearly defined beginning and end. This first example, caring for patients with chronic disease, does not describe work with a beginning or an end. Encounters with patient may be discrete, but this EPA is not written in a way that captures that. In contrast, admitting a patient from the emergency department for an acute medical presentation has a clearly defined beginning and end to the task. As such, it would be scored here. This item asks if the EPA is discrete in process. Consider the example of documenting a progress note. This is not something done in isolation, but as part of a patient assessment and care. It clearly depends on multiple other tasks to achieve a meaningful outcome. By contrast, assess and manage an inpatient with an acute medical complication is a standalone task. It may occasionally require additional tasks such as consulting specialty services, but typically can achieve its outcome as a standalone activity. The third item in this category is to ensure that the EPA is appropriately focused. It is easy to develop EPAs that are too broad in scope. The first example EPA here, managing infectious diseases, is clearly too broad and only captures a general area of practice. The second example, assessing and treating patients admitted with acute medical presentations to acute care settings, is much more focused. It may involve some closely related units of work, but it is specific and clearly focused in purpose. The fourth item asks if this EPA is observable in process. The example here of comforting a dying patient shows how there are things we do that are important but not really observable. You can't actually observe the experience of being comforted. An equivalent EPA that would be observable is caring for patients at the end of life. This would capture comforting, but focus on behaviors of the clinician which are observable, not the experience of the patient which is unobservable. The fifth item is that the outcome of the EPA is measurable. This may be measurable in descriptive terms, not just quantitative terms, but the EPA must have an outcome that can be directly judged. The first example, delivering care professionally, just describes how something is done. There is no associated product of the work. In contrast, assessing and treating patients with new and acute medical presentations has an outcome that can be well described. Certain aspects of the outcome, including certain complications of treatment, may only be captured indirectly, but largely the outcome from this EPA can be clearly judged. The sixth and final item under this category aims to distinguish a given EPA from the other EPAs in the framework. From a practical standpoint, it's important that when answering this item, raters have a complete list of all EPA titles in front of them. Otherwise, this question becomes impossible to answer. The first example provides two EPAs. Reading them, it is difficult to distinguish these EPAs in any meaningful way. In contrast, these EPAs, although they have similarity, also have important distinguishing features. The first EPA describes the initial resuscitative care for unstable patients. This would focus on things like advanced life support. The second EPA describes the management of patients that have already been admitted to the ICU for ongoing treatment. With similarity, but clear and important distinguishing features, this would be scored here. This is the last item in the rubric for this category. Beyond operationalizing competencies into discrete, independently executable activities, EPAs must also be essential and important tasks of the profession. This flows logically from the principle that these are the tasks that society trusts the members of the profession to perform at a consistent and high level. Further, society's trust also implies patient well-being is linked to the outcome of the activity. Entrustable also implies that there are individuals who are specifically qualified to be trusted to perform these tasks. Typically, this refers to activities that demand a high degree of skill in their application. There are many things we do to help patients, but professional entrustment relates specifically to those activities for which training and certification in the profession is required. It should also be recognized that there are things important to the sustainable practice of medicine that are not suitable to entrustment from society. Maintaining work-life balance and avoiding burnout are examples of important goals for successful practice. Although important, these are not things society entrusts physicians with in their clinical care. In essence, activities that are entrusted by society are those that focus on the care and well-being of the patient. The examples of work-life balance and avoiding burnout have physician-focused goals and outcomes. This first item asks whether the activity is essential to professional practice. The first example, participating in hospital administration, is essential for our healthcare system, but is of very low importance to actual professional practice. In contrast, developing collaborative care plans is very important. There may be cases in which it is not relevant, but overall, this would be considered very important and expected for practice. The second item in this category looks for a relevant outcome that can be attributed to the professional work performed. For example, treating patients and caregivers professionally is another example of how we do something, but not something that leads to an outcome or product. The next example, lead a family meeting, clearly does. Although the outcome from family meetings may be variable, there is typically some defined result that can be attributed to it. The third item examines whether this is an activity restricted to qualified personnel. This is to establish whether the activity is something that is specifically entrusted to this profession. For example, assisting patients with ADLs is something frequently done by untrained persons, including family members. The second example, assessing geriatric patients for frailty and developing comprehensive collaborative care plans, is an activity that requires training and qualification to perform independently. It may not be exclusively entrusted to physicians, but it does require training and certification to be entitled to do this. The final item in this category evaluates whether the EPA is suitable for entrustment. This is examining the outcome of the EPA for a patient-centered benefit. The first example, as discussed earlier, is physician-focused. This is important but not entrusted in the sense of clinical care. The second example, participating in hospital quality of care reviews, is not clinical work, but is an activity society expects as part of self-governance. Further, it contributes directly to improved patient care. This would align here in the scoring for this item. EPAs are intended to enable direct assessment of clinical learners who are attempting to achieve defined outcomes by performing specific activities. From this perspective, it is important that EPAs integrate with competency-based medical education curricula. First, EPAs should reflect the knowledge, skills, and attitudes, or KSAs, that learners acquire over the course of training. Further, EPAs should capture how learners integrate KSAs from across domains into professional work. This allows EPAs to be carefully blueprinted in curriculum development, enabling the connection between learning events related to that EPA to assessment strategies that capture performance. In traditional curriculum development, learning objectives were written to focus on the learner. Objectives described a specific learning goal and included a time frame, criterion for achievement, and conditions. The assumption being that if each of the objectives were achieved, the overarching goal would be. EPAs represent a departure from this traditional approach. As units of work, EPAs differ from traditional learning objectives in that they describe the application of knowledge and skills in professional activities. They do not describe the learner. This is important as CBME aims to produce graduates able to apply their skills more than simply having learned them. Finally, as units of work, EPAs should not be written with adjectives or adverbs that reference proficiency. Qualitative description of learner performance is appropriate during clinical assessment. The EPA itself, however, is simply the unit of work. Take this EPA as an example. I've written it in two forms. The latter is the preferred structure in which the verb is the activity itself. In both examples, the term appropriate references the proficiency of the learner in performing the task. This should not be included in an EPA. You can also see the adjective common is used. In this case, common is a clarifying adjective for the task and does not reference proficiency. Adjectives used in this way may overly narrow down EPAs, but they do not describe proficiency, which is the concern addressed here. This item evaluates if the EPA requires KSAs that are acquired through training. This is important as EPAs are meant to support the assessment of the outcomes of training. The first example is really about the trait of altruism. Although arguments could be made that this could be learned or at least simulated, altruism really represents a personal trait, and not one typically addressed through curricular design. In contrast, caring for patients at the end of life requires KSAs that are gained through training. The second item in this category looks at whether the EPA integrates multiple domains of competence to perform the professional work. This integration is essential to successfully applying the skills learned in a clinical context. The first example, demonstrating empathy, is a somewhat particular quality, an important one, but one that does not adequately capture even a single domain of competence. This EPA does not capture integration of competencies. Performing the procedures of internal medicine, by contrast, requires several domains, including communication skills needed to obtain informed consent, procedural expertise itself, and collaborative skills in working with nurses and staff. Although procedural expertise may be considered dominant, this EPA necessarily includes these other aspects. This third item distinguishes between EPAs written like learning objectives, which focus on the learner's competencies, or as EPAs that describe the work. Sometimes the first clue that is written as a learning objective is that it begins with demonstrates. Ideally, the EPA captures work and only the work. In this example, communicating verbally with patients, the EPA captures only a learner's communication skills and does not reference a specific activity in which it's applied. This example specifically describes the work in which competencies are being applied. It could also be argued that this could be scored in the final category as purely a description of work. The emphasis on discussing and establishing does put some focus on the learner, not simply the activity. Either scoring could be reasonably supported. This is the item that refers to the use of adverbs or adjectives. The first example here includes two adverbs. These both demand interpretation and should not be included in writing the EPA. The second example does not use any adjectives or adverbs related to proficiency, but does imply standards or proficiency in the qualifier to assist with specific aspects of patient care. For this reason, it would be scored here. The EQUAL rubric provides those involved in developing EPAs for their specialty a structured approach to evaluating EPA quality and identifying aspects that need to be improved. The rubric was built to measure how well EPAs serve the goal of operationalizing competencies to enable reliable assessment that predicts future performance at an acceptable standard for the profession. It makes use of the peer-reviewed literature to define EPAs and to look for misunderstandings and shortcomings in how they are written and described. Finally, and of particular importance, the rubric is criterion-based and has been subjected to a standard-setting exercise by a panel of medical education experts. Normative evaluation is not appropriate for measuring the quality of EPAs, as the goal is not to compare the relative EPA worthiness amongst a panel of EPAs, but to define them against an accepted standard. This rubric provides this. Thank you for completing this training video in advance of using the EQUAL rubric.